All right, so welcome to today's session of Healthy Discussions. Before we get started, I have just a few housekeeping notes. The chat box and Q&A feature are both open, so please feel free to use them. You can also turn on subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. This session is being recorded and will be posted on Quality of Care NL's YouTube channel. I'd like to acknowledge that we are joining you from the ancestral territory of the Beothuk, and that the lands on which Memorial University's campuses are situated are in the traditional territories of diverse indigenous groups. We acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat, and to take a moment to reflect not only on why we offer these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. For those who aren't familiar with Quality of Care NL, we are a research and evaluation program based at Memorial University aimed at improving social and health outcomes in our province. Healthy Discussions is a webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussion also contributes to the growth of a learning health and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning health and social system, as defined by Health Accord NL in its task force report. I can see that Dr. Samak has joined us. Thank you. This definition might seem complicated the first time you read it, but what it really boils down to is a health and social system that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for all. Part of the definition states that individuals and families are active participants in all elements. By engaging in sessions like this one, by being an active participant in your own healthcare and wellness, and by talking about and acting on issues that impact us as a society, you are contributing to a learning health and social system in our province. This week is World Antimicrobial Resistance Awareness Week, a time to build awareness and encourage everyone to take action to combat antimicrobial awareness, or AMR. Many participants light up landmarks, wear blue, and use the color to go blue for antimicrobial resistance on social media and at in-person events. On November 26th, the Confederation building here in St. John's will light up blue in recognition of World AMR Awareness Week. Today our discussion will focus on using antibiotics wisely. We are delighted to have joining us Dr. Peter Daly, an infectious disease physician and co-chair of the Provincial Antimicrobial Stewardship Committee, and Dr. Elami Samak, please let me know the preferred pronunciation, family physician in Burgeo and president-elect of NL College of Family Physicians. Joining them for today's discussion is Quality of Care NL's director, Robert Wilson. Robert has some questions to get our conversation started, but we will also be taking questions from the audience. Please type your questions in the Q&A box, which is a little easier for us to manage. Sometimes questions can get lost in the chat as people chime in with their thoughts. Since today's discussion is being recorded, you may wish to ask your question anonymously, which you can do so by using the Q&A instead of the chat. You can find that using the little three dots in the bottom right corner. I'll now pass it over to Robert to introduce today's discussion.
So before we get started, I just want to share a few facts about AMR, or antimicrobial resistance. So it occurs when bacteria, viruses, and fungi and parasites no longer respond to antimicrobial medicines. And as a result, antibiotics and other antimicrobial medicines become ineffective. And some alarming facts coming from the global is 5 million association deaths every year associated with AMR. There's up to $3.4 trillion US yearly global economic loss by 2030, and it is the top 10 of global health threats, and this is recognized by the World Health Organization. So antimicrobial resistance is a threat to global health, food security. It threatens our ability to protect our societies against infections in humans, animals, plants, and the environment, including water supplies. And finally, I do believe so. Every year within Antimicrobial Awareness Week, the WHO, the World Health Organization, has a theme, and this theme is that AMR is invisible, but I am not. And some alarming quotes coming from some patients that were affected by antimicrobial resistance. So antibiotic resistance bacteria in my lungs are the greatest threat to my life. My right shoulder got infected. I've had 19 surgeries on it so far. And my family struggled financially for 10 years, all because of an untreatable fungus. And finally, a healthy student athlete, I was nearly defeated by a simple infection. So you can see some powerful words coming from there. So for my first question, it's for you, Dr. Daly. We just talked about AMR in the context of the global threat. As an infectious disease physician, can you tell us about AMR is affecting us here in Newfoundland and Labrador?
Thanks a lot, and thanks everybody for joining us today for World Antimicrobial Awareness Week. A good opportunity for us to review this very, very important public health problem. So I work with antibiotics and I work with antimicrobial resistance, and the perspective here is that antibiotics cause changes in the germs that live in us and on us, and they become resistant to antibiotics. And unfortunately, these resistance genes transmit between people and animals, between animals and environment. And so this problem affects us all globally in kind of a One Health approach where we think about what's happening ecologically. You know, when patients come to me, they're generally coming with an antimicrobial resistant infection. And I find it increasingly difficult to find antibiotics to treat patients like this because, and we test this in the lab, we find that the drugs that we would like to use, we simply cannot use. So this problem is a very big global threat to our health. And the predominant issue that we would like to change in the province of Newfoundland would be reduction in antibiotic usage. That is to say that antibiotics are given to patients unnecessarily contribute to this problem. How does that work biologically? It causes a selection and change in the genes within these germs that live in our flora, on our bodies and in our bodies. And those resistant organisms are transmitted between people. So when you take an antibiotic unnecessarily, you're actually contributing to the problem on a global level. So it's quite important that the message to our patients in the province becomes, do you really need to take an antibiotic? Because most patients who come to a primary care clinic with a respiratory tract infection or a urinary tract infection don't actually need an antibiotic. And yet we're giving antibiotics to these patients very, very commonly. It's very easy to get an antibiotic. I can call up a telehealth provider and I can get an antibiotic very quickly. We are losing these drugs because we're giving them too often and unnecessarily. Thank you.
So, I mean, that's a good segue for my next question, Dr. Samak. You are a practicing family physician in rural Newfoundland, Labrador. You would imagine during the cold and flu season, you're going to see a lot of patients coming in with upper respiratory infections. So how as a family care physician, how do you explain to your patients that they don't need an antibiotic?
So thank you for giving me the opportunity to be participating in this antimicrobial awareness week. So when patient comes to us here in the ER or whether in clinic with complaining of cold or flu-like symptoms, first of all, we have to be very empathetic with them and make sure that we understand their concerns, understand their symptoms, and provide them with a plan. We need to educate our patients about the cause of their illness, and that cause is a virus or a viral infection that doesn't require antibiotic treatment, and that antibiotics are only used to be treating bacterial infection, which is not viruses. That's the first thing, is we explain to them what is the cause of their infection. And then we talk about why don't we use antibiotics. The abuse or recurrent use of antibiotics will lead to microbial resistance, which will lead to serious complications in the future. That we need to be stressing on that point with our patients. Then we need to provide them with a plan. the plan is, okay, you're having cold or you're having flu-like symptoms. That's we're gonna give you some instructions like increase your hydration intake. Maybe if you have some fever, take some Tylenol or Advil as needed to control your symptoms. If you have some cough, some remedies like honey or whatever can help with your cough. And then tell them like if you don't feel better within a couple of days, you come back to us for follow-up. So when we provide a follow-up plan, that gives them some sort of reassurance that we'll be following up with them. And lastly, we need very importantly to assure them that viral infection is usually self-limiting conditions. They're gonna get better with time. Just give it some time, and you'll feel much better. And antibiotics are not always the solution for your symptoms. Thank you.
Thanks. And so I'll pass it back over to you, Peter. So, I mean, we're talking about the community here right now. So, I mean, perhaps you can discuss whether there's a lot of common misuse within a hospital setting or a long-term care setting, and maybe some, you know, what's the repercussions of this?
Thank you. Most antibiotics are used in Canada in the community, that is in outpatient settings. About 20% are used inside hospitals. Inside hospitals, we have careful controls that we apply to try to use antibiotics appropriately. We have susceptibility testing. We have specialty physicians who come and offer recommendation. So by far, the focus is not on the inpatient, but rather on the outpatient usage. Long-term care is another place where we see a lot of antibiotics get overused. The common reason for overuse of antibiotics in long-term care is delirium with positive urine culture. This is not a urinary tract infection, and yet when the urine culture becomes positive, that is, bacteria are grown in the lab, the physician feels prompted to give an antibiotic, and that's an inappropriate antibiotic. How common is inappropriate antibiotic therapy? We don't really know, but we certainly estimate it as 1/3 to 1/2 of all prescription in the outpatient setting. That is to say, we could significantly reduce antibiotic use in the clinics and in the long-term care, and yet not cause any harm to the patient. So where we're giving a treatment which is unnecessary, we're actually contributing to a harmful problem. So this is why the thinking needs to change. The thinking of the patient, the thinking of the family of the patient, the thinking of the provider, where we need to be very restrictive about who would receive an antibiotic for an unnecessary indication.
Thanks. So over to you, back to you, Dr. Smack. So, you know, Quality Care and NL have kind of analyzed antimicrobial or drug use within the province for quite some time. And it's been kind of shown that within rates, within rural areas, that it is much higher when compared to urban areas. Can you perhaps speculate why the reason for this is?
So I think the rates might be higher in rural areas for maybe multiple reasons. One of them is access to healthcare. Most rural communities either don't have a physician on site or don't have access because they live far away and they are only accessible by some sort of ferries or other methods. So they end up having either virtual appointments or telephone appointments with some healthcare provider who cannot assess the patient individually or in person and end up prescribing antibiotic for fears that they are missing on something that exists or doesn't exist. That's one thing. Other thing is probably patient expectations. Most patients, when they have any sort of questionable infection, they are expected that they want antibiotics and antibiotics will make them feel better, and that provides some sort of a pressure, especially for people working in a rural community, because you see these people, sometimes they are your colleagues in the hospital, sometimes they are the grocery store staffing, that you deal with them on a regular basis, that provide you some pressure that I need to prescribe them antibiotics to satisfy them, which shouldn't be the case. Sometimes it's like healthcare provider habits or not good practices, like just prescribing antibiotic for every complaint or everything. Other things that might be leading to that is chronic medical conditions. People like with COPD or diabetes so end up presenting to the emergency department frequently for worsening conditions. So why not give an antibiotic? So maybe that will help. Lastly, which is very important, is lack of education. Like we need like lots of communication, education to patients that not every single condition will require an antibiotic, and mostly they are viral infections that will be self-limiting, and just give it some time and you'll feel better. And antibiotics is not always the treatment or the cure.
Right. So before I go back to some of the questions I've got for you guys, Michael, I'm going to ask whether or not do you see any questions coming from the audience?
Nothing at the moment, Robert, but I am keeping an eye on it. And again, everyone is welcome to submit questions.
Perfect. So I'm going to go back to you, Dr. Daly. You co-lead the Provincial Antimicrobial Stewardship Committee. Can you perhaps just tell the audience what that committee does, what their mandate is, and perhaps some of the initiatives that they're doing currently?
Sure, yeah. Recognizing this global problem, all hospitals define an antimicrobial stewardship committee. And we work in hospital, and we work in outpatient, and we work in long-term care settings. We have a pan-Canadian action plan designed to help us federally to work on reducing antimicrobial resistance. And I'll summarize some of our activities in our stewardship committee. One important activity is surveillance. That is, we measure antimicrobial usage and we measure antimicrobial resistance. And we are only developing this in the province for the first time, which is really good measurement that shows us which direction we are going. We have excellent national data showing antimicrobial resistance is worsening. And we have some provincial data showing that antimicrobial usage, although it went down during COVID, is probably continuing to increase or return to where it was before. So a big part of our work is surveillance. A second part of our work is infection prevention and control. That is, we try to prevent these resistant organisms from traveling between people when they're in hospital or when they're in clinic, and that comes to hand washing, isolation, gowning, and gloving, that sort of thing. A third part of what we do is leadership. That is, we can advocate to administration to provide us with support, pharmacists and other staffing, to really try to intervene as much as we can to change physician behavior, change patient expectation. A big part of that is education. And then research is a big part of what we do too. So we have some novel approaches that may actually contribute to helping in this problem. One of them is offering rapid point of care virus diagnosis. So we have a national study that we're participating in right now, and people in the winter season with an upper respiratory tract infection can present for a nasal swab for free, which tests them for 4 viruses and gives them immediate answer at the time that they're seeing the clinic. And we think the advantage of that is if we tell a patient, the news is you actually have COVID-19, influenza, respiratory syncytial virus, that the patient will become convinced that they do have a viral infection, and therefore there would be no advantage to taking an antibiotic. So at a research level, we have that type of initiative. And we really hope that if we can provide a faster diagnosis that is immediately in front of the patient, it will work to try to reduce antibiotic overuse. We'd like to encourage patients to come to the Mundy Pond Clinic for a swab. If you have a cough, a cold, a fever, a sore throat, a runny nose within the last 5 days, Mundy Pond is currently open and receiving patients for testing. And you'd be contributing to our research project. And the benefit to you is you get a free test and a free diagnosis. So that's some of our strategies, Robert.
Perfect. That's a nice little plug for your research project too. Yeah. Dr. Smock, can you perhaps fill us in on, for clinicians, prescribing clinicians working in the community, what could they possibly do to ensure that they are prescribing antibiotics wisely?
So I think the first step would be like education and communication. So educating our patients and ourselves that viruses don't require like treatment with antibiotics. Educate our patients about the course of illness of any cold or flu-like symptoms or any different illnesses that don't require per se treatment with antibiotics, and providing the patient with a follow-up plan that would like set the expectations about that this is like a self-limiting condition. It will get better. You can come back to us if things doesn't get better, and we'll take care of you at the time. That's one thing, is the education and communication. Other things that can help also, the antibiotic stewardship programs using evidence-based medicine about the dosage and the duration of treatment, because sometimes they are overprescribing. Yes, this condition will need like an antibiotic treatment, but they are giving like broader spectrum of antibiotic for a longer duration that's not really needed or required, that can cause sort of resistance in the future. Using admission order sets at the hospital, like which preset with in this condition, this is the best antibiotic and this is the best dosage and this is for that certain duration, helps as well with controlling our prescribing habits. Pharmacists, the on-call pharmacist and the pharmacist at the hospital, they can provide feedback about, like, they put an end date for the antibiotic. This shouldn't be going on for this long period. Reconsider your diagnosis, reconsider your treatment plan. Maybe something else is missing. For accessibility issues, because working in rural community, most patients don't have easy access to physicians or nurse practitioners. Sometimes delayed prescription for antibiotics. So he tells them, try this, no antibiotics, and some over-the-counter medications, and I'll give you a prescription for antibiotic, but don't use it unless your symptoms gets worse in the next, like, maybe 48, 72 hours. That's something that can help as well. We don't have, like in most rural communities, I believe, that set up for auditing our antibiotic prescription, but that would be like a good idea to have a resource like this to control how much antibiotics are we giving, and whether we are over-prescribing or over-usage of antibiotics unnecessarily. So those are all the things, I think, that will help in a community setting in rural practice to control our antibiotic prescription.
Okay, thanks. I think I saw something pop up in the chat there, Michael. There's a question from the audience.
Yes, so Sarah Donnelly Harnham asks, the most common scenario I encounter is UTI in the pregnant population. Can you provide some guidance on reducing antibiotic use in this group? So open to either.
Yeah, I can talk about that. Thanks, Sarah. Looks like you're a midwife, so you take care of a lot of patients who are pregnant. That's fantastic. Urinary tract infection during pregnancy is a risk for pyelonephritis, and we do screen with urine culture late in pregnancy for the purpose of treatment for that condition. It is a risky condition. I would not discourage antibiotic use for urinary tract infection in pregnancy. That's really not the scenario that we're mostly interested in changing practice. There is a federal recommendation on screening of all women during pregnancy using urine culture for the purpose of preventing pyelonephritis. So that might be a situation where we're not exactly reducing antibiotic use.
Thanks. So kind of on that thread too, Peter, I'm going to go back over to you and ask a similar question I asked Dr. Samak about how do you ensure clinicians prescribing medications don't overuse or misuse antibiotics within a hospital or a long-term care setting?
Yes, thank you. We have many initiatives that we use. One is called peer comparison. Peer comparison is a report to the physician that describes to that physician their rate of usage and compares it to other physicians' rate of usage. And that can actually be quite effective to reveal to a doctor that that person is over-prescribing. In hospital, we use what's called prospective audit and feedback, and this is a structure when we come on day 3 of admission, and we review without consultation, and we provide recommendation on discontinuation, narrowing of spectrum, or at least fixing of duration. In long-term care facilities, we've had a new medical directive put in which empowers the nurse to make decisions about collection of urine culture. So really, the problem in long-term care facilities is we collect urine culture too frequently, and we collect it on patients who don't need to have it collected. That is to say, a lot of our patients, frail, elderly, and long-term care facilities have positive urine culture every single day. It's a syndrome called asymptomatic bacteriuria. And so we certainly wouldn't give an antibiotic to a positive urine culture when patient has a positive urine culture every single day. That's a meaningless lab test. So the real approach in long-term care facilities is to limit the collection of urine. In fact, the lab, we've talked for many years about restricting access to the test. Why should we do a test when it's unnecessary and potentially harmful to the patient, in that it will produce a lab result which will prompt a physician to act unnecessarily? So a number of initiatives are in place to try to guide, to try to steer. I should mention our First Line app. If you're interested in appropriate use of antibiotics, we have the First Line app in Newfoundland and Labrador. It's a free public app. It's provided to physicians, it's provided to nurses and pharmacists, but it's also provided to patients. So go ahead and download that right now, the First Line app, and you enter your location. And that'll give you very specific medical recommendations about appropriate therapy, including withholding of antibiotic therapy. There's a lot of useful decision support available in that app. I should say we're also developing national antibiotic treatment guidelines through AMI Canada and Public Health Agency. Those guidelines will be in the First Line app for all physicians across the country, not just within one province, to guide appropriate antibiotic usage. And we encourage patients to become educated. You know, if you're a patient on the webinar today, you are the one who should be understanding appropriate antibiotic use. Of course, your physician should understand it very, very, very well, but you also should be informed about which syndromes would require an antibiotic and which syndromes would not require. Thanks.
And I mean, this I'll just sort of mention here now, and this will be a question for both of you guys, is the fact that you know, for Choosing Wisely, it's hard not to mention Choosing Wisely here. Choosing Wisely Canada, for those who don't know, is a national voice for unnecessary tests and treatments within Canada. And of course, Choosing Wisely Canada and Choosing Wisely NL, antibiotics has been a major project and a major initiative to provide education and resources for not only the public, but also clinicians within the province and the country. So, I mean, this could be a simple yes or no answer, but do you guys use the power of Choosing Wisely Canada and Choosing Wisely NL within your practice? Peter, I'll ask you, Peter, first.
Absolutely. Strongly support Choosing Wisely and put Choosing Wisely directly into our First Line app to promote to all providers. Choosing Wisely is the voice of reason when it comes to unnecessary or inappropriate treatment in Canada.
What about you, Dr. Samak?
Absolutely as well. I second what Dr. Daly said, and First Line app and Choosing Wisely, that's a very important resource for all clinicians regarding antibiotic prescription and usage and guidelines. Thank you.
Thank you. So I'm going to go back to some of the questions. Oh, we have a question from the audience here, Michael. That's the cue.
Yes, so we have one from Samantha Allen, who asks, are there any areas within Canada or other countries that are having good success with reducing antibiotic resistance or reduction in inappropriate antibiotic use?
Yeah, thanks for that question, Samantha. There are countries in the world that use antibiotics at a very low rate, and those are Scandinavian countries. And these are countries with excellent health and no concern about patients being undertreated or dying of infectious diseases. These are countries with excellent health systems. We are middle of the pack as a country in terms of antibiotic use. There are many countries at higher rates, tending to be countries where access to care may be weaker, that is lower middle income countries, Africa, Southeast Asia, Middle East. These tend to be countries with high antibiotic use rates. And we can understand that because these are countries that don't have access to good diagnostic testing. A lot of patients take antibiotic over the counter without a prescription. So as we sit among rich countries, we are middle of the pack. And there are rich countries like Scandinavia, which have much lower rates than we do in Canada. Across Canada, Eastern Canada is the worst and Western Canada is the best. So we have a high rate here in Atlantic Canada compared to Ontario, Alberta, BC. So that gives you some comparison.
Thanks. Are there any more questions, Michael? Was that the only one?
That is all for now.
So I'm going to go back over to you, Dr. Smack. I know we sort of briefly mentioned choosing wisely, but you know, within the community, obviously, particular in the community that you serve and provides healthcare services to, is there any sort of stewardship initiatives that perhaps you would like to see or see promoted within the community?
Definitely. So in here in Bergio, like in this community, there hasn't been any like sort of education to the public or communication to the public about antibiotic microbial resistance or antibiotic stewardship programs. I know that they do exist, but maybe the word need to be sent to the public. So sort of maybe through social media campaigns, using all different social media accounts, YouTube, Facebook, or whatever other options available to distribute the message to the patients about antibiotic usage, the complications that arise from antimicrobial resistance, the course of illnesses that don't require antibiotics at all, uh, other options that might be helpful also in rural communities, maybe direct communication with physicians, like what Dr. Daly said about having sort of audit or feedback about antibiotic usage and peer. I haven't heard of that program. I haven't received any peer comparison between myself and other physicians about my antibiotic rate usage. But that would be like a great idea to learn and be individualized. I don't know if collaboration with pharmacies would help about the rates of antibiotic usage as well per physician and per patient. Uh, Also, I don't know if that's an option in our community or in general about like having incentives for physicians or nurse practitioners who are doing good antibiotic usage compared to others. That maybe will help promote the situation that like not every patient will need an antibiotic. But education, that would be like
Yeah.
best
Okay.
to the community and to the patients, definitely.
Yeah, this sounds like a pretty good agenda item for the stewardship committee, Peter. And you know, just to kind of add on, you know, to talk about that sort of peer comparison and providing usage for physicians and nurse practitioners, it's something Quality of Care and Choosing Wisely NL has done in the past, and perhaps it's a topic that we'll have to revisit and look into again. But I totally agree. You know, education, and you know, that's a job for the stewardship committee and for our group, absolutely, to get that reach out there and educate the public for sure. I don't know, Peter, I don't know if you have any other comments for that sort of.
Yeah, thanks for saying that you would be willing to look at peer comparison, because peer comparison works. We clearly know out of Ontario that peer comparison changes behavior. So strongly support peer comparison. In fact, we have money in a national study to do peer comparison. So very much like to get back into doing peer comparison within the province. Interesting that you bring up incentives. That's a very good political suggestion. We should pay physicians more to do good quality medicine. We should pay physicians less to do poor quality medicine. And in fact, in the UK, they've done that. And they show that people are motivated by that as an incentive. So that's completely politically difficult to even imagine in Canada, but that would be a nice way to consider making practice change. I firmly believe in measurement. I think if we measure, we will see change simply because we measure and we provide the data to the users. And that's what Quality of Care is doing, and we'll continue to provide that.
I do see. Oh no, you did already ask this question, did you, from Samantha? But I have one more question for you, Peter, before we perhaps go to the audience for any more questions. Michael, we have an infographic to kind of sort of describe this question that I'm going to ask Peter. So I'm going to ask you to just pop that up there, if you don't mind. So antimicrobial use is in healthcare that is contributing to AR, but it's also the usage within animal health and food and agriculture industries. So can you tell us a little about how these other factors contribute to AMR?
Yes, and encourage, we have 27 people on our call today. Please have a question ready because we'd love to hear from you. If you're a patient, if you're a healthcare worker, we'd love to hear from you. So this is the One Health approach, which says that what happens among humans affects what happens among animals, affects what happens among the environment. So totally different from any other global public health problem, we have to consider the implications among all organisms living in this planet. They are the microbes, they are the animals, they are the fish, they are the plants, they are the humans. So it's completely unique for me as a physician to consider the implications of human medicine on animal medicine and on environment medicine. We know that antibiotics are highly used within animal husbandry and agriculture. And unfortunately, antibiotics are used inappropriately in these settings. If an antibiotic is given to a pig or a chicken or a cow to grow and to produce more profit in the meat industry, that is not the right use of an antibiotic. If an antibiotic is given to an animal or a fish that is sick and needs treatment, that is the right use of antibiotics. But clearly, the industry has developed profit from using antibiotics in an inappropriate way. Antibiotics are not for growth promotion. Antibiotics are not for prevention of bacterial infection. Vaccination works for that. We should never use an antibiotic for those reasons. And what happens among the farms and the fields may affect what happens among the health of humans. So this is a new concept that we're thinking about in the field and scientifically saying we have to be at the table with the veterinarians and the farmers and the biologists, people who work in the environment. Everybody has to care about this problem together because if we fix it only among humans, we are not going to address the problem affecting the other groups. So it's kind of an exciting way to think about the ecological effect of antibiotics.
Thank you. I don't see any questions popping up in the thread. Perhaps I'll leave it up to Dr. Daly and Dr. Smack. Like, what if you could perhaps sum it up in a sentence, what would you tell the public right now, or even your peers, about the use of antibiotics? Dr. Smack, I'll start with you.
Sure. So I'd say like antibiotic is not the answer. Not every problem or not every disease will require antibiotics. And education, communication to our patients will help them understand the cause of their illnesses and help with their plan and follow up to avoid our unnecessary use of antibiotics. Thank you.
Peter?
Yeah, the message today is ask a question. If you're a patient and you're considering whether you need an antibiotic, consider alternative therapies. Have a discussion with your doctor. Don't do the same thing you've always done. We have lots of patients who say, every single winter I expect an antibiotic. No, you don't need that. So question your own medical care if you're a patient. And if you're a provider, please reduce your antibiotic usage by 1/3 to 1/2.
Michael, is there a question coming from the audience?
We do, and I think we have a good bit of time left. So,
Yep.
Christina asks, is there strong evidence that education campaigns focused on patients rather than providers are effective for reducing rates of antibiotic use? Thank you, Christina.
Yeah, I can talk about that. Thanks, Christina. We always sort of say, is this a physician problem or is this a patient problem? And often the physician blames the patient and often the patient blames the physician. It's a silly argument. The problem is with the patient and the physician, or the nurse or the pharmacist, whoever's prescribing the antibiotic. We do have evidence that certain educational interventions work to reduce antimicrobial usage. Dr. Samak mentioned the delayed prescription. The delayed prescription works. If you provide a prescription to be filled 2 days from now, it tends not to be filled, and that does reduce antibiotic consumption. We have a tool called the viral prescription pad. The viral prescription pad says, you came to see your doctor today. Your doctor cares about your symptoms. You've been diagnosed with a virus. Here's some over-the-counter solutions and symptomatic measures that may be beneficial for your symptoms, which are not an antibiotic. That is called the viral prescription pad. We don't have evidence that other education campaigns that I know of work, but we still feel it's useful. When we color the Confederation building blue, we hope people are asking the question, why is it blue? And somebody is able to say, actually, we're promoting antimicrobial resistance awareness this week, and we want people to understand what that is. Well, what does that mean? People don't even know what that antimicrobial resistance means. So we have seminars like this, and we put a poster on the waiting room wall if you're seeing your primary care provider and the poster says no amount of antibiotics will help you with your cold and flu. We're trying to get that message out. So we do focus on educating the patient and we focus on educating the provider both.
Right. And I mean, I guess particularly in antibiotics, I guess it, and like you alluded to this earlier, Peter, that like within prescriptions, there's the data for an indication of why a drug is given is not really captured. So a question like that, some of these questions are really hard to answer with that, and particularly with antibiotics, where it's not a long-term use drug, it's just used for a certain ailment for a short period of time, and it's a one-time op as opposed to other long-term chronic drugs that perhaps are used within the community. I do see one question that popped up here from Lisa, and perhaps I'll ask Dr. Samak this question. What are the alternative treatments for UTIs? And for those who don't know, that's a urinary tract infection.
So, hydration. That's one thing that helps to wash out infection. Some patients find cranberry juice helpful as well as an alternative. Sometimes that it's just self-limiting and will get better on its own without any intervention or any procedure, just a matter of time. So those are all options that are available, and actually those all recommendations to give to patients when you see them for possible or questionable urinary tract infection before you rush into prescribing antibiotic and give them a script. Follow up as well and educating them about what to look for, what symptoms they might get, and when to come back if needed. That's all help with providing the patient with workup plan and reassurance, and will limit the need for antibiotic usage. Or sometimes patients all we need to hear from you is just reassurance. They are not expecting anything. Yes, there are patients that come with expectations that I'm going to need an antibiotic, etc. But the others are just coming and you just need reassurance, and that's more than enough for them.
Thanks. Any more questions coming, Michael? It doesn't look like it. I have one serious question to ask both of you. Do antibiotics work for chronic rain and fog? No? I tried.
If only.
If only. And I'll go back to you, Dr. Samak. You talked about education. And so for those who are online and perhaps who are going to watch this recording after, I highly recommend for you guys, for the public to educate themselves, use resources such as the World Health Organization, Choosing Wisely Canada, Choosing Wisely NL, that have a lot of evidence out there of the misuse of antibiotics and when not to use an antibiotic. Before I pass it over to Michael to conclude today's session, I want to thank Dr. Daly and Dr. Smack. I know obviously, Dr. Smack, you're taking time off and perhaps your lunchtime here during your clinic. So we're very grateful for you to come on as a guest and educate us and talk about antibiotic stewardship. So without further ado, Michael, I'm going to pass it over to you to conclude today's session.
Thanks, Robert. So once again, I want to thank all the panelists for leading us through a great discussion, Robert included, so we can all become more informed about this important topic. A big thank you to everyone who joined us online. Thanks for listening and participating as well. Just a reminder that the recording of this session will be up on our YouTube channel in the coming days, so just search for Quality of Care NL, and you can check out the recordings of all previous sessions there as well. Lastly, you'll see a very short post-event survey on your screen after we end the webinar. We'd appreciate you providing any and all feedback or ideas for future healthy discussions. Thanks again, and have a great day.